Hello, everyone. So I just wanted to introduce the first speaker of the day is Dr. Joseph Croffie. He has been a mentor of mine for well over the past decade, and he's always whoever we ask whenever we have a difficult procedure to do. He has been here at Indiana University throughout his career and is an international expert in pediatric constipation and motility. So he's going to talk to us today about motility testing and how these are traditionally and how these tests are used to diagnose motility problems in children with neurodevelopmental disorders. Welcome, Dr. Croffie.
Thank you. I'm going to go ahead and share my screen now. Okay, so I'd just like to thank all the organizers for inviting me to participate in this. This is, really nice and exciting. You can all see my screen, right?
Yes, we can. Go ahead and hit
Okay.
slideshow if you can.
Great. Wonderful. Okay. So my assigned talk was to talk about traditional diagnostic strategies in pediatric gastroenterology and the challenges of the application to neurodevelopmental disorders. I have nothing to disclose. So some of the common problems that we see in patients with neurodevelopmental delay or disorders include oral motor dysfunction. We always wonder whether they are aspirating. The patients may also come to us with complaint of vomiting. Then we have to kind of wonder whether this is due to gastroesophageal reflux. Is it due to rumination? Is it due to some GI dysmotility? They might come to us with constipation. And again, when they come to us with constipation, we have to kind of wonder whether this is due to a functional disorder or is it due to an organic disorder? They might present with diarrhea. And when they come to us with diarrhea, again, we have to consider whether this is functional or is it infectious? Is it due to small intestinal bacterial overgrowth? Is it due to malabsorption or maldigestion? Or is it due to inflammatory bowel disease? So all of these would go through our heads as we see the patients. The challenges associated with investigating the children usually include communication issues. These children usually have unable to explain or to describe specifically what their symptoms are. There's always a difficulty understanding why the test needs to be done in these individuals. As you all know, some of them may have sensory integration difficulties, which might make it difficult for us, especially when we're attaching sensors to them to do these motility testing. Of course, GI doctors are notorious for sticking tubes in orifices, which is usually not tolerated even with kids that don't have neurodevelopmental issues. But certainly, with the kids who have neurodevelopmental issues, they may not tolerate us putting tubes in different orifices. And because of that, there might be a lack of cooperation from them for us to perform these tests. Also, some of these patients may have comorbid conditions. So they might have heart problems or they might have respiratory problems that might make performing some of these procedures challenging for our patients. So let me start off with oral motor dysfunction, which we may see in some of these patients. The consequences of that are that there is defective swallowing, and when the patients swallow, there's a pooling of material in the throat, which then leads to a risk for aspiration. How do we diagnose this? Well, we typically will diagnose it with video fluoroscopic feeding study, which is shown over here. This video fluoroscopic feeding study is usually done by a radiologist and a speech pathologist. And what they're doing is that they're introducing different textures of food and liquids to these patients to see whether the material is swallowed appropriately and if it goes where it's supposed to go rather than into the lungs. Now, the difficulty is that the patient has to cooperate with them. So, as you know, some of these patients with neurodevelopmental disorders have texture issues and they might refuse to consume the material that they're being given, which then creates a problem for us. Another way to look at these patients is to do a fiber optic endoscopic evaluation of swallow. So this is usually done by ENT surgeon who would use a flexible scope pass it down, into the oropharynx, and then the patients will be given different textures of food or liquids, and then the ENT person will then observe as they swallow to see which direction is going. Of course, this has to be done with an awake patient, and as you can see, the patients with neurodevelopmental disorders may have difficulty tolerating such a procedure. So how about the patient who presents with vomiting? So when they come in with vomiting, again, we're considering whether the vomiting is due to gastroesophageal reflux. So some of the ways that we diagnose this would be to do an upper GI contrast study. So when we do an upper GI contrast study, our goal is actually look to make sure that there's no anatomic explanation for why the patients are having these symptoms. Unfortunately, the upper GI contrast study by itself is not an adequate test to look for gastroesophageal reflux, because we're not able to differentiate between pathologic reflux and physiologic reflux. So for example, in this X-ray that you're seeing here, the patient swallows and the radiologist might report that there is gastroesophageal reflux. But if this happened during the time when the study is being done, then we're not able to say whether this is physiologic or pathologic. Therefore, in most of these individuals, if we're really worried about gastroesophageal reflux, we have to do an esophageal pH study to see just how much exposure the esophagus has to acid. Sometimes we would have to do endoscopy, but when we do endoscopy, if the endoscopy is normal, then we really cannot tell. If it's abnormal, then it might actually indicate to us if the patient has got reflux or not. So doing the esophageal pH study usually requires putting a catheter down the nose into the esophagus. Typically, we use an impedance pH probe. So here's a catheter here, which is an impedance pH probe catheter. It's got these sensors on there that conduct electricity. And basically what you're looking for is resistance to current flow as material goes from one sensor to the other. So as you all know, liquid poses less of a resistance to current flow. So if the patient is drinking liquid, you're going to see a drop in impedance as the material goes down the catheter. And if it is going antegrade, then we know that it's a swallow. If it's going retrograde, then we know that it's reflux. And the way we differentiate between reflux, which is acid, is that there's a pH sensor at the end of the catheter that detects the acidity of the material that's going either direction. So in this tracing here, you see the patient with reflux where you see retrograde flow of material, and then the pH sensor actually detects a pH of less than 4. So this patient here has acid reflux. On the other hand, this patient here is also refluxing, but the material is not acid because the pH is above 4. So again, the difficulty with this is that the patient has to be awake when we place the probe, and quite often in patients with neurodevelopmental disorders where we have difficulty, even in the kid that doesn't have a neurodevelopmental disorder, there's always difficulty passing this probe down and having them keep it there, for 24 hours for us to record what is going on in the esophagus. So then, so here's a happy young man who's got a probe down his nose, and he seems like he's happy, he's laughing, but most of our patients aren't going to be like this. So they're not going to keep it down, and the problem is that they might actually pull it, and we would not get the data that we need. So quite often then what we have to do is we have to do endoscopy, which requires obviously anesthesia or sedation, to place a pH probe, which is a wireless pH probe, what we call a Bravo probe, and we place it during endoscopy, and we can then record the pH of the esophagus wirelessly to tell us whether the patient has got acid reflux or not. The disadvantage of this is that we only get one data. So we get data on pH. So we can only pick up acid reflux. And obviously, if the patient's symptoms are not due to acid reflux, then we're not going to be able to pick it up. So for example, a neurodevelopmentally delayed person that's refluxing and getting aspiration from it, we would not be able to tell if the patient refluxes material and the material that's being refluxed is not acid. We won't be able to tell on that in that study. So that's the disadvantage of this particular way of evaluating the patients. The advantage is that you have a probe that's in the esophagus and they're not going to be able to pull it out. So what about the patient who's presenting with vomiting where we're thinking that they might be ruminating? So if the patient is coming in with vomiting and they vomit, within 10 minutes after eating, the first thing that comes to our mind is that they might be ruminating. So this is where this, these individuals might do that either for attention or due to some gratification that they get from it. We typically would do an esophageal manometry, to diagnose that. So the esophageal manometry, the tracing that you're seeing in a normal esophageal manometry, where you're looking at peristaltic wave going down the esophagus. The tracing here on the right is a patient with rumination, where you actually see a simultaneous high amplitude spikes of pressure in the stomach and the esophagus. And then obviously the patient then regurgitates material into either their mouth and re-swallow or spit it out. So these are called R waves, and the R waves are consistent with rumination, where we can then make the diagnosis and provide the appropriate treatment then for the patient, so that we're not going to make a diagnosis of gastroesophageal reflux if the patient's problem is really rumination, which obviously requires a different approach to treatment. So again, as I said, esophageal manometry requires that you put a catheter through the nose and keep it down. And also while we're doing the study, we're asking the patients to swallow. We give them liquid, bolus of fluid to swallow. We typically don't want them to swallow frequently because it makes it very difficult for us to interpret the study. And so the patients have to be able to cooperate with you. And when you ask them not to swallow, they should not swallow. And when you ask them to swallow, they should swallow. So that obviously becomes very difficult when we're dealing with somebody with neurodevelopmental disorder. What about the patient who is vomiting? Well, we're worried about a GI dysmotility. So if we're worried about a GI dysmotility, we might consider, especially if the patient is presenting with conditions such as abdominal distension, or they come in with retching and gagging, vomiting, and they're not tolerating food, especially if they have, some of these patients would have, for example, a gastric tube, or they might have a GJ tube, and we're feeding them through the GJ tube, but they're still not tolerating it. So then we're worried about some generalized GI dysmotility, and we might then want to do an we might want to do an antroduodenal motility study to determine whether the patient's got abnormal intestinal motility. Do they have a neuropathy, or do they have a myopathy? So as you can see, the patients are usually hooked up to a computer. We're recording, so we place the motility catheter with endoscopy, so they're under anesthesia when we do it. But then when they wake up, we have to take them to our motility lab and hook them up to a computer. So for some of these patients with neurodevelopmental disorders, just the whole setting of the room itself might actually be something that might create panic for them. They might not be very comfortable in that environment with all these machines. And then you have to kind of have them lay down for a period of about 6 hours to record, so we can get a tracing, which you see in here, a normal tracing of, gastric contractions and small bowel contractions. And our abnormality would be if the contractions aren't propagated and if they go in the opposite direction, then that's usually a neuropathy. And if the contractions are not very strong contractions, so the amplitudes are low, but the propagation is correct, then that's a myopathy. So that's what we're looking for to tell us whether the patient's got some kind of, abnormality of gastrointestinal motility. Now, obviously, there's a problem here if the patient's got a neurodevelopmental problem of keeping them in the room, them cooperating with us over the number of hours that we're doing the study, so that we can get a good study that's not polluted by artifact. What about the patient that comes in with constipation? So when they come in with constipation, generally for pediatrics, when we see patients with chronic constipation, we think of functional constipation. 90% of our patients have functional constipation. So that's what we're going to think about. So the patient goes to see the primary doctor, and the primary doctor does an X-ray, which shows a large amount of stool in the colon. And now they've referred them to GI. This is a patient with a neurodevelopmental disorder, and we're trying to figure out what to do. Is this functional or is this organic? Obviously, we have to consider the possibility of an organic disorder. So what do we do for these patients then? Well, we might do a barium enema, for example, which will allow us to look for anatomic abnormalities. We might do an anorectal manometry, which allows us to look for the rectoanal inhibitory reflex, which is relaxation of the internal anal sphincter, the sphincter of the anus when the rectum gets distended. If this reflex is absent, then we're either dealing with Hirschsprung's disease, or we're dealing with a condition that's called anal achalasia, which used to be called ultra short segment Hirschsprung's disease. That means that the anus doesn't relax when the rectum gets distended. So these patients are going to be constipated, and often require surgery to fix it. The other thing that the anorectal manometry allows us to do is we are able to assess the rectal sensation. So we distend the rectum with different volumes of air to see whether they can feel it. They're able to tell us when they feel the urge to go. We're able to measure resting pressure and squeeze pressure, and we can examine dynamics of defecation by asking them to bear down, so we see what they're doing when they're bearing down. So obviously this requires interaction, so they have to be able to understand what we're asking them to do, and they have to be able to do the things that we ask them to do for us to get a meaningful result from this study. And that often becomes very difficult in these patients. What about, if we want to look at transit, one way that we can do this is to do a radiopaque marker study where the patients swallow radiopaque markers, and we look to see how it goes through the GI tract to see if it actually comes out of the GI tract. Again, this might be difficult for us to do in this patient population. We can do a colonic manometry, which then requires us to put a colonic motility catheter, which we do under anesthesia, and then measure contractions of the colon to see whether the patient is normal or if they have a neuropathy or a myopathy, as I pointed out earlier in the antroduodenal motility study. So here's a contrast study, a barium study looking at the colon in the patient that presents with constipation. So here again, the radiologist has to put a tube into the rectum. So that means that the patient has to cooperate with them. And then they have to then fill the colon with contrast. And here you're looking at a contrast study of a patient with narrowed segment of bowel at the rectosigmoid junction and a really dilated sigmoid colon. This is actually a patient with Hirschsprung's disease. But again, as you can understand, the patient has to be able to cooperate with the radiologist as they perform the study. And typically in the patients with neurodevelopmental disorders, we might have challenges doing this. We can do an rectal manometry, and when we do that, what we're looking for is what we call the rectoanal inhibitory reflex. Again, as I said, that means that distension of the rectum should cause a relaxation of the anus. So on this tracing here, which is a traditional line rectal manometry, you see that the rectum is being distended with different volumes of air, and you see in relaxation of the sphincter as the rectum gets distended. The same thing is shown here in beautiful color, which is a high resolution manometry, where again, you're distending and you're looking at the anus, and with each distension, you see relaxation, of the sphincter. So that's what we're looking for. But again, as I said, patients have to cooperate. We can make the diagnosis of Hirschsprung's disease with this test, where now we're distending the rectum with air. This is the anus up here, and we're distending, expecting to see relaxation of the sphincter, and we're not seeing that relaxation of the sphincter as we distend. Again, in the high resolution tracing, we're distending, and we're not seeing gaps in between the pressures in the anus as we would expect to see in the patient who's normal and doesn't have Hirschsprung's disease. With the traditional, with the anorectal manometry, we can also pick up abnormalities that are functional that we can treat. So we can pick up dysenergic defecation where the patient is contracting the anus while they're also bearing down at the same time. So if you look at this tracing here, you see in a traditional tracing, a normal individual where you ask the patient to bear down and you see an increase in pressure inside the rectum and you see relaxation of the anus. The next tracing next to that is dysenergia, where the patient is bearing down but is also squeezing the anus at the same time. And if you want to look at it in color with the high resolution manometry, again, the patient is bearing down and you see pressure inside the rectum and you see relaxation inside the anus, as opposed to the patient who's bearing down and also squeezing the anus at the same time. So you see pressures go up both in the rectum and in the anus, the rectal pressure being the pressure in the top bar and the anal pressure being the pressure in the lower bar. So again, the patient has to be able to cooperate. They should understand what we're asking them to do, and they should be able to do the things that we ask them to do. This often is very difficult in some of these patients. At the end of it all, the patient, again, as I said, has to lie down and participate with us during the study as this young lady is doing, which often may be difficult, for us to do in this patient population. I talked about the transit studies. So again, this is where the patients swallow a capsule that contains radiopaque markers, and then we get x-rays and look to see how the capsule goes through over 4 days, up to 7 days. So in this tracing x-ray here, you see here you see the capsule containing the plastic material, which is a radiopaque material. So this is again, trying to get the patient to swallow this. And that might be difficult. And a lot of these patients, getting them to swallow it might be tough. But they have to swallow it so that we can then get x-rays and follow over time to determine whether the patient is actually moving those the radiopaque materials through the colon into the rectum. The first tracing here is showing a patient with colonic inertia, where the material is staying in the right colon and doesn't seem to be moving. The next tracing is showing all the contrast material, all the radiopaque material in the rectum. So you can get this in a patient who has dysenergic defecation or who's holding it. But you could also get in a patient who's got an outlet obstruction. The third one is just showing the radiopaque markers all over, which indicates slow transit constipation. So all of these would require different ways to treat, and it's important for us to know so that we can provide the appropriate treatment for the patient. So again, we have to have cooperation from the patient to be able to do that. So the other way that we typically would look at motility of the colon would be to do a colonic manometry. So when we do the colonic manometry, we do a colonoscopy, and then we place a motility catheter, which is a long catheter that's got pressure sensors that are spaced a certain distance along the catheter. Again, we can place this during colonoscopy, which is done under anesthesia, and then the patients then have to be brought to the motility lab and hooked up to a computer, just like I showed with the antroduodenal motility earlier on. So again, the study is done over about 4 hours, 4 to 6 hours. The patient has to cooperate because they move around a lot. Then we get a lot of artifact and we can interpret the study. So, if they cooperate with us, then we will be able to tell whether they've got normal colonic manometry. So you're seeing here contractions that are propagating down the colon. And you're seeing one that's abnormal, that's showing the propagation stopping somewhere in the middle of the colon and not going all the way down. And in this tracing over here, the third tracing over here, there are no contractions at all. So we can make that diagnosis. But again, if the patient is moving around a lot, or they're not really laying down still while we monitor or measure these, we're going to have difficulty interpreting it because we get a lot of artifact, movement artifact, and it makes it difficult for us to interpret the study. Other areas where patients might present would be, again, as I mentioned, chronic diarrhea in these patients with neurodevelopmental issues. We're then considering whether they have a malabsorption or maldigestion or an infectious problem. Obviously, the first thing we do would be to send a stool sample to look for something infectious, and if that comes back and is negative, then we have to try to determine whether we're dealing with a functional problem like irritable bowel syndrome, or are we dealing with just functional diarrhea, or are we dealing with some kind of maldigestion or malabsorption or small intestinal bacterial overgrowth. So a non-invasive test, particularly to look for maldigestion, so for example, lactase deficiency or lactose intolerant, or to look for small intestinal bacterial overgrowth, will be to do a breath hydrogen test where we provide the patients with a substrate. The substrate might either be lactose, or it might be glucose, or it might be lactulose. And then we just have them, take this substrate, and then we have them breathe into this bag here, and we measure hydrogen. So the thinking is that, bacteria that lives in the colon can break down these sugars and produce hydrogen, which we can then capture. So depending on the time when there's a peak in hydrogen spike, that will tell us whether the patient is malabsorbing the sugar we're giving them, or if right at the beginning of the study, we measure a very high level of hydrogen in their breath, then that might tell us that we're dealing with small intestinal bacterial overgrowth. In other words, as soon as the material hit there, the bacteria that lives in the small bowel actually broke it down and produced the hydrogen. So now you have to get the patient to cooperate with you to do a breath hydrogen test, right? So you're going to put a bag over their face, and you're going to ask them to breathe into the bag. A lot of, as you all know, a lot of these patients with neurodevelopmental issues might have sensitivity issues. They don't want to be touched and that kind of stuff. Putting a bag over their face might actually cause some difficulty with them. They might be scared. And then asking them to breathe into the bag might also be a challenge. So that this becomes, a difficult test to do in this group of individuals. So then when we're faced with that situation, then obviously what we fall onto is to do endoscopy. And we can do endoscopy then, which allows us to look at the mucosa, so that we can get mucosal biopsies in these individuals. We can biopsy for histology, and we can do a disaccharidase analysis in these patients. We can collect duodenal fluid for bacterial culture. The unfortunate thing is that endoscopy requires anesthesia or sedation. And in most of these patients, some of these patients may have comorbid conditions like heart problems or respiratory problems, then that makes even endoscopy a challenging test to do. So in just conclusion, summary statement, in patients with neurodevelopmental disorders who present with GI symptoms, it is often very difficult to determine whether the symptoms are due to a functional disorder or an organic disorder because of their inability to appropriately communicate their symptoms. Ignoring their symptoms may lead to underdiagnosis, but investigating is challenging. Patience and empathy are important for us to avoid over-investigating, but investigate enough to make the appropriate diagnosis so that the appropriate care can be provided for these patients. Thank you for your attention. I'm going to stop sharing now.
Thank you very much, Dr. Croffie. That was very informative. I absolutely appreciate how at each point you talked about the difficulties in these tests that occur with those with neurodevelopmental disorders. It's important to keep in mind. I'd like to introduce our next speaker. This is Dr. Baha Moshiree. So she is the Director of Motility in the Division of Digestive Health at Atrium Health in the Carolinas Medical Center. She focuses on problems like gastroparesis and irritable bowel syndrome. She's heavily involved in the neurodevelopmental disorders community. She comes from the adult side of motility, which, as it turns out, is even more of a rarity than it is in the pediatric side. And we absolutely need more people like Dr. Croffie and Dr. Moshiree who are able to help with some of these more complex problems. Dr. Moshiree is going to talk to us about how she monitors outcomes and what we can do for measure improvement. Welcome, Dr. Moshiree.
Thank you so much, Billy. And I really enjoyed Dr. Croffie's talk. As always, he's also my hero. And hopefully this won't be redundant, given he did such a thorough presentation going over the pediatric world, but I'll skim through the ones that he already was able to discuss today. So I'm really proud to be part of this team of experts, including Billy Bennett, Kara Margolis, and Dr. Dolman, who really got me interested in this area of specialty. And so usually prior to this, I was taking care of patients with spinal cord injury, neurogenic bowel, Parkinson's disease, multiple sclerosis, but really prior to going to University of Miami, where I met Julia Dolman, I was not really familiar with children that have autism spectrum disorders of any kind. And so we know that these are very common symptoms that we see in the general population of adult patients, but specifically in autism spectrum disorders, these measures of reflux, abdominal pain, nausea, vomiting disorders, dysphagia are really hard to evaluate for us. And Kara yesterday really went over the gut-brain interactions and the connection between the neurologic side and the GI tract, and so did Andreas. And so although we know these symptoms are common, and they correlate with their behavioral disorders and that there is a gut-brain connection, we don't really have easy ways of measuring these in real time. And why is gut motility important? Well, motility specialists really handle kind of a lot of these other disorders. We end up with a lot of these zebra disorders that other physicians in the gastroenterology world may not have the expertise in to take care of. And we do know that there's this phenomenon of the immune system, the dysbiosis in the gut and its interactions with the brain that affect motility. And motility is the protective side of the GI tract that really takes care of these issues. So whether it's functional or motility disorder really doesn't matter in the big scheme of things, because what we do is we take care of patients' symptoms, because that's what leads to the impairment in their quality of life. So the gaps in treatment in neurodevelopment disorders have been acknowledged by all of us. We all know that there's lack of proper, easily used patient-reported outcome measures for nonverbal patients. But I think even in pediatrics, there's not really good PROs that are set up for systemic diseases. So I work with the Cystic Fibrosis Foundation, and they have the exact same issues because there's not PROs that specifically are addressing cystic fibrosis in general. Even so, for neurodevelopment disorders, it's almost worse. And then the other issue is that even in the general population, symptoms that occur in the upper GI tract and the lower GI tract cannot be differentiated from each other. So for example, bloating can be an upper GI symptom, but it can also be a lower GI symptom. Patients who have gastroparesis can have neurogenic bowel, and patients that have neurogenic bowel with severe constipation, it can cause a delay in gastric emptying. And so oftentimes there's so much overlap that it's difficult for us to just do one diagnostic test for our patient. So this is why Dr. Croffie's presentation was so comprehensive, talking about the esophagus, the stomach, the small intestine where bacterial overgrowth happens, and then also the colonic motility issues. And then specific diagnostic testing and consensus is not available for neurodevelopment disorders at all. There's also lack of available and expert GI physicians. I don't even consider myself an expert gastroenterologist in neurodevelopment disorders because I feel like there's so much that I still need to learn about the actual disorder, the behavioral issues, and then really to work together with a neurologist like Andreas would be phenomenal. And we actually don't have one at HUM Health, and probably a lot of facilities don't have one. And then there's no treatment algorithms that have been proposed by any societies, and of course funded studies, but that will improve with time. So of course, these children with autism spectrum disorders will be transitioning from the pediatric world to us. And I would definitely say that the pediatric world has done a phenomenal job of taking care of patients, and that in the adult world, there's a transition that's missing, and there's many desperate parents, as we heard yesterday, looking for adult GI physicians who aren't just scoping for colon cancer screening. And I think that's one of the issues that's occurring nationally, and oftentimes there's a lot of desperation with trying to find the appropriate physician to take care of patients. The other issues are that there is a significant amount of fecal incontinence that also we then take care of in the adult world. And then, you know, just it becomes very difficult. So how we define constipation in adults, in the adult world with functional constipation, there's a set of symptoms. It's lumpy hard stool, straining, sensation of incomplete evacuation, manual maneuvers, and then having less than 3 bowel movements a week is the actual Rome 4 functional definition. But the other symptoms such as bloating, distension, and then most importantly, abdominal pain are not part of the functional constipation definition. They're more seen, especially abdominal pain, in patients who have irritable bowel syndrome, as Billy was talking about yesterday. So in adults, how do we evaluate gut motility and transit? And again, this is in the general population. The causes of constipation are very complex. So it could be medications, especially in the adults, they're oftentimes on several medications. It could be their seizure medicines causing nausea or constipation. It could be other blood pressure medications, so many other causes, NSAIDs, of course, narcotics in the general population tend to be a huge issue, but not in neurodevelopment disorders. And then Dr. Williams talked about dyssynergic defecation and pelvic floor dysfunction, where Botox may be helpful in some of these patients, but of course, that's not something we can do chronically. And then a small segment of patients even in the general population, less than 2% probably, have colonic dysmotility that we call slow transit constipation. And Dr. Williams talked about, Dr. Croffie too, about colonic manometry. So there's very few patients that we will do colonic manometry on in the adult world for evaluation of constipation. And these are the objective measures that we have. So we have colonoscopy. We only do colonoscopy if they're over 45 years of age. That's for colon cancer screening, but it's not necessarily for evaluation of constipation at all. And then there's transit studies, there's whole gut scintigraphy that is done in very few centers because it's labor intensive, it takes 5 days to do, and it's really expensive. There's radio-opaque marker study that Dr. Croffie talked about already. I'll talk about wireless motility capsule that is FDA approved for adults to evaluate for whole gut transit. And then anorectal manometry, Dr. Croffie went through very thoroughly. There's balloon expulsion testing. And then in adults, we also do MRI defecography that helps us determine if there's a structural issue with the anorectal area. I'll skim through the colonic manometry since it's been talked about, but what is the utility? So this is in the general population. What is the utility of diagnostic testing for chronic constipation? Really, the only 3 tests that have been recommended that received a grade B/A recommendation have been the radio-opaque marker study, the wireless motility capsule that we'll talk about, anorectal manometry, and then balloon expulsion testing. So barium enemas, colonoscopy, x-rays, thyroid testing and stuff, they're really not recommended. Now, Billy talked about how, many of the symptoms in our patients with neurodevelopment disorders are like irritable bowel syndrome, because the kids have, abdominal pain, they will have constipation, or some folks in the chat brought up, what about diarrhea? Like, what if they have diarrhea instead of constipation? So in irritable bowel syndrome, the guidelines came out last year. I was involved. And for diarrhea predominant IBS has 3 subtypes. There's diarrhea predominant. We recommended that a fecal calprotectin, which evaluates for inflammation, be done, or a CRP to evaluate for inflammation. This is to rule out inflammatory bowel disease and make sure that this is not, this is not inflammatory bowel disease. Crohn's disease, ulcerative colitis are the ones we're talking about. And then celiac testing, if they have diarrhea, should be done. This is with a serum IgA level, which is an immunoglobulin test, and then also a tissue transglutaminase. That's an easy blood test that can be done. There's also giardia if, there is a high risk. So if there's a history of camping, drinking water from not city water, things like that would be a risk factor. Colonoscopy only if the, if the adult is over age 45 because of colon cancer screening. And if there's alarm symptoms like anemia, bleeding, etc., of course, weight loss, a colonoscopy should be done. Mixed type IBS is probably where a lot of parents, I think, were describing yesterday, was that what about mixed symptoms of diarrhea and constipation? This is where stool diaries can be helpful. And I know they're laborious, but stool diaries are very helpful in this realm, but there's really no treatments for IBS that's mixed type. And then KUVs may be helpful in this patient population. And then for IBS with constipation, we really recommend now anorectal physiology testing. In the guidelines, we weren't able to give it a grade methodology consensus agreement because there was not enough data, but this is more suggestive of a pelvic floor disorder. And, for that, we do biofeedback therapy with a physical therapist that can be very helpful in adults, but that's very difficult in a patient that may not understand the instructions. So it really requires cognitive ability. So scintigraphy is how we evaluate upper GI symptoms. So this is symptoms of nausea, vomiting that we think are not rumination disorder and they're not cyclic vomiting. And so what the patient does is they go to the radiology nuclear medicine department. They are given a specific meal. They go, fasting. And this is like a not really palatable egg sandwich that they get with 2 pieces of toast and 2 eggs. And it gets labeled with technetium. And then they ingest this over 5 minutes, they're supposed to, and that's a big sandwich for them to do. And then over time, at 1 hour, 2 hours, and then up to 4 hours, we scan them, and then we see how much of the meal is maintained in the stomach. And if there's over 10% that's retained in the stomach, we call it abnormal, and that's a that's an abnormal test, meaning they have gastroparesis or delayed gastric emptying. The problem with this is that there is radiation exposure. And of course, we don't prefer that in kids, but it's a minimal radiation exposure. And so this is something that pediatricians will order in their patients, and we do it in the adult world all the time. So new in the gastroparesis world and the gastric evaluation is MRI. So MRI gives you a nice dynamic image of the gut. This is not done, but in very specific centers in the United States even, and then in England where it was initially done. And it gives you kind of a nice coordinated picture of what happens in the stomach. So normally when food comes into the stomach, the anterior of the stomach part, it's called the fundus. So the initial part that accommodates the food is the fundus, and that expands. And then there's contractions that motilin receptors help with, and then there's these rhythmic contractions that we can actually measure. There's also newly created, so for example, the top one, A, is a healthy control where you see these rhythms in the stomach, much like the heart. And then in a gastroparetic patient, they're all over the place. So it's a very, unorganized contraction that occurs. And you can actually map these out. There's also something called the electrogastrography that's very similar to like EEG that's done for seizure disorders. And this is like a patient wears like a belt that goes around the stomach. This has been created by the folks in New Zealand. And for the past 2 years, it's been all over our DDW and our societal meetings. And this kind of creates a nice way to evaluate gut motility, and it's non-invasive. And that's something that could be easily done once it's FDA approved and comes to the country for diagnostic purposes for evaluating gut motility. So that's in the research phase right now, but I'm very excited about it. So this paper that I'm showing here is an explanation for why we decided to do this blue muffin test with Dr. Julia Dahlman as part of her NIH grant, her R21. And this is basically a study that looked at patients who had ostomies and they had diarrhea and short bowel syndrome. And they put this blue marker in their meal and gave them like this sugar substrate that they drank. And then they saw how long it took for the blue dye to be seen in their ostomy bag. And so we kind of imitated that study and tried to create these muffins that are more palatable in children, since the gastric emptying meal is not palatable. And we created these muffins that have the same exact, amount of protein and calories and carbs as the gastric emptying scintigraphy one, and then put this blue dye in it, and then looked at patients that had GI symptoms with autism spectrum syndrome versus the ones that did not, and then compared them and saw that the ones that had GI distress, the time of transit was actually prolonged. And so we have very few patients that we've signed up for this. We went through the pandemic, so had trouble like recruiting patients, and then had to get the muffin created by a baker. So now we're at the phase where we can actually study this. So we're excited about that. And then anorectal manometry, Dr. Croffie talked about, we do this often in adults to evaluate for pelvic floor disorders, but it's not going to be as easy to do in children. And even the adults don't really necessarily enjoy this test, but it's very informative, and it tells us whether there's a neuromuscular disorder. The catheter goes into rectum, and it does require that the patient be involved with the test. So they have to do squeezes, they have to do pushes, and then they sit on a commode, and we time how long it takes them to have this balloon exit. And then, so for example, in a patient that would have dyssynergic defecation in the middle part, as they're pushing in the bottom, the pressures are actually going up. And so this is how we determine whether the patient should get Botox injection into the sphincters, which we do very rarely, as it can cause fecal incontinence in patients, or if we're going to do biofeedback therapy with a physical therapist. So now we move into medication targets. So, I helped publish this in a Parkinson's journal. So this was really about upper GI meds in Parkinson's disorder. Patients do have gastroparesis oftentimes. And so these are just the drugs that have been developed for that specific disease process, and that can be helpful, and they're targets. So there's drugs that work on the dopamine receptors, they're antagonists. There's drugs that work on acetylcholine. Serotonin is a big target for many of these drugs. There's also drugs that are ghrelin agonists that help the appetite and satiety, which may be a problem. There's motilin agonists, those are antibiotics, unfortunately. So there's a risk of resistance. Erythromycin, azithromycin. In the pediatric world, we give those often in liquid form for patients who have gastroparesis. And then there's others that are listed here. So there are some drugs, but there's not a million. And the only FDA approved drug for treatment of gastroparesis causes a lot of neurologic disorders, including what's called tardive dyskinesia. And that drug is Reglan and metoclopramide. So the non-generic name is metoclopramide. Again, that's the only FDA approved drug, and it has a black box warning where you cannot give the drug, you should not give it for more than 3 months, and especially not in an elderly population. And then for the lower GI tract, there's a lot more medications that we can give. So the good news is, in the lower GI tract, we have a lot of options. So we have serotonin agonists. They work on serotonin that's secreted by enterochromaffin cells. That helps motility. There's osmotic laxatives. There's stimulants that Dr. Williams was talking about yesterday. There's intestinal chloride channel activators that they're called guanylate cyclase agonists, and those work very well. And then there's drugs that now, the latest is the one that works on the sodium proton channel that helps kind of secrete water into the colon, and patients can have bowel movements. Now, as far as diagnostic testing, wireless motility capsule is a capsule that the patient ingests. It goes through the entire gut from stomach down to the rectum, and it tells us transit and motility indices. So the contractions as it goes through the intestines. And so this is on a patient that actually had autism, one of my adult patients who suffers from constipation and has a bowel movement every 5 to 6 days. And that's usually without use of laxatives, but this patient's on like 5 or 6 laxatives. And so we do the test off laxatives, off any proton pump inhibitors, because the pH of the intestine is how we determine the transit. So in this patient, we found, and this patient had upper GI symptoms, lower GI symptoms, and we couldn't really differentiate them. And the symptoms were like vomiting and also constipation. So the gastric emptying was actually normal, surprisingly. Small bowel transit was about 3.5 hours. It was normal. But then the colon transit time was 113 hours. Now, that could be that they have colonic dysmotility, or it could also be that there's a pelvic floor disorder and the capsule could get stuck in the rectum. So usually when we see that, we can do anorectal manometry for the patient to determine that. Now, management strategies. So these are the drugs that are available for patients to treat them for constipation or pain, abdominal pain and constipation. So I've differentiated them into whether they help pain, bloating, or constipation. So the drugs that help constipation are the water-soluble fiber can help, over-the-counter laxatives like milk and magnesia. Then there's these drugs, these are the lubiprostone, linaclotide, and plecanatide. These work on the chloride channel. And then there's tenapanor, that's the newest drug that works on the sodium proton channel. It's an antagonist. And then there's prucalopride and tegaserod. These work on serotonin. Prucalopride, I see my pediatric colleagues give often to their patients with constipation. It also helps gastroparesis based on European studies, but not US studies. It is only FDA approved for chronic idiopathic constipation. Then there's these drugs, all these drugs that work on, the constipation symptoms also help bloating. And there's several trials that have looked at that. There's the low FODMAP diet that we don't do for patients with neurodevelopmental disorders, but this is a kind of a diet plan that's standard therapy for irritable bowel syndrome, and it can help with the bacterial overgrowth and intestinal dysbiosis. And then there's drugs that help pain. So all these drugs that help constipation, they also have a second mechanism that they work on, cyclic GMP, and they help at the synapses and the neurons, they help the pain that's experienced by patients. So they do have secondary, benefits. And then there's antidepressants. So we call these neuromodulators, serotonin receptor antagonists that can help. And then of course, in an adult population, we do send them for psychological therapy, cognitive behavioral therapy, etc. So what's new? The apps can be very helpful. I know there's several apps, it sounds like that are being developed, but streamlining these and all of us working together would be fantastic because they can help research across a patient's lifespan. They're much more accessible. They're easier for the caregivers to do, and they can be easily modified. And they allow us, especially with COVID happening, to gain data even virtually. And then just to show you guys this is a, an app that's being developed by a company called Dieta, and the FDA is actually working with them on several new like industry sponsored studies. And so it captures the stool image in real time. So the patient with their smart app takes a picture of the stool, and then it tells the clinician the consistency of the stool, the volume, it has to be the same toilet that's used every time. But then also the patient doesn't have to use this Bristol stool scale, which I know a lot of the parents yesterday were pointing out was very laborsome. And this AI was accurate in the initial studies as compared to 2 expert physicians from Cedars-Sinai evaluating it. So hopefully we'll see newer studies coming out with this. And then our own symptom tracker with Dr. Dahlman that's been developed with the help of one of our University of Florida students, Dylan Baker. And this has been developed to help caretakers track GI symptoms, and it's like easily used and has pictorials that can be very helpful in terms of them being able to mark the symptoms that they're able to verbalize. And so for functional bowel diseases, lastly, what's been proposed is, self-reported symptoms, but we have to have PROs to be able to get them. What is the diagnostic workup? We are trying to make sure that the minimal amount of workup is done, but for neurodevelopment disorders, this is something that really helps us determine the pathophysiology so that we can then do targeted treatments and targeted interventions for the issue. But we are trying to minimize the amount of diagnostic testing that patients undergo and really try to treat the symptoms rather than treat the diagnostic study in general. And then my acknowledgements are to Julia Dahlman, who got me into this, and she's had several grants. And we do have an ongoing study right now at Atrium Health, which is the study with the blue muffin. And so hopefully if you have any patients, please have them contact our clinical team. And Jessica is our main coordinator, and her email is below. So thank you so much for the invitation.
We did get some questions and we're tracking them, but we don't have time to give them right now. Billy or Alicia, is there any instructions before we move on to the next room?
I think the only thing to bring up again is just to remind folks that there's that all these are recorded if you missed any part of it, and that those will be available perpetually. And then to remind folks to that we can't answer questions about your child individually. And we're going to move on to our next session. I believe, Alicia, it's your turn to. Do you have any other announcements?
No, I think Kate is going to run a video.
Thank you very much, Dr. Croffie.
I think it'll be in the,
Dr.
so
Moshiree.
it'll be in the next, at the beginning of the next session. Sorry. Thank you, guys.
All right. Thank you guys very much.